Good evening, ladies and gentlemen. It is my great pleasure indeed in order to be with you on the third ILEP International Lipid Expert Panel, the webinar 2020, which will be completely dedicated to acute coronary syndrome lipid-lowering therapy in time of the COVID pandemic, and not only because it is the very challenging issue, not only in the time of COVID-19 pandemic. I am together this evening with my great colleagues and very recognized experts. Professor Zlatko Fras from Ljubljana, from Slovenia. Zlatko, thank you very much, you are with us. Professor Dariusz Dudek from Krakow. Hello, Darek. And Professor Arman Postadzhiyan from Sofia, Bulgaria. I'm very happy that you have joined me this evening, because the issue, in fact, is a very, very important, and your great experience, everyday clinical experience, is critical in order to answer all the most important questions regarding the suitable management of lipid disorders, of dyslipidemia therapy in patients with acute coronary syndrome. Within this webinar, we would like to answer all the questions. We are after the new guidelines of the European Society of Cardiology, European Atherosclerosis Society, with the new thresholds of LDL thresholds. On the other hand, we have the PCSK9 inhibitors, which are not available in all the countries, European countries. So we would like to know how we might be on the target of the therapy without or with PCSK9 inhibitors, and whether they are indeed necessary, or in what proportion of our patients we are able to be on the target with intensive statin therapy and ezetimibe, with the combination therapy. We would like also to say a little bit more why it is important to be on the target, because it might be associated, it is probably associated with reduction of the cardiovascular outcomes and all the other issues we will discuss together. And that is why during the presentations, I would like to kindly ask you to ask questions, because at the end of the fourth presentation, we'll have 30 to 40 minutes in order to answer all the questions. And our aim is indeed to discuss all the most important issues concerning lipid-lowering management in acute coronary syndrome patients, because it is our aim of the webinars. We don't want to show how clever we are. The most important issue is in order to give you the knowledge to use in everyday clinical practice. Okay. But I don't want to prolong this introduction any longer, and I would like to kindly ask Professor Dariusz Dudek, the president of the European Association of Percutaneous Interventions. It is our great honor and pleasure that Professor Dudek is with us, and I would like to kindly ask Professor Dudek to make his presentation. Darek, the floor is yours.
Thank you very much. Good evening. Thank you for the invitation. So I will show you the perspective of interventional cardiologists and perspective of people which are dealing with acute coronary syndromes, and why it is important for us to take care of our patients. Okay. So first of all, when we go to guidelines, so we know that all patients after acute coronary syndrome, myocardial infarction, unstable angina, those patients are very high-risk patients, and this is number one. When you consider interventional cardiology, let's say that we have some issue and problems in the past, and we are related to have, after interventions, some reinfarctions, which were related to stent thrombosis. But nowadays, when we look for the all reinfarction after a successful PCI, there is no longer issue, so it means stents are safe, antiplatelet therapy is good, and even we can reduce antiplatelet therapy. But the issue are completely different. The difference are that the events are related not to the culprit lesion, but they are very often related to non-culprit lesions. So it means from other territory, from other part of coronary arteries, we have a lot of problems in interventional cardiology. We are just treating with the focused treatment the one spot, but we need much better treatment for our patients in other territories. It's very important also when you go to numbers that you see that in 1 out of 5 patients who are event-free for the first year, OZMR, they suffer a mild stroke death within 3 years. So it means that even successful treatment of the patient with acute coronary syndrome, it's not everything, because you still need to treat patients after successful focal stenting of the entire coronary artery tree. This is very clear for interventional cardiologists, and I can assure you that many cardiologists they are taking care of this and they are aware. We are seeing that there is a change between 2016 and 19 over last years in the threshold, and for very high risk group patients, we should be now with the target less than 55. And all of us, we know that it's not so easy all the time to achieve those numbers. And the thresholds are lower and lower. We know that we have the recommendation to use high dose statins for all patients. Interventional cardiologists are rather brave and they try to use the maximum dose or almost maximum dose of statins during the discharge. And they should, of course, to have target. This is, for me, a little point for discussion. That recommendations are saying that we should re-evaluate patients 4-6 weeks later after ACS, which is, of course, good. But I think that we should re-evaluate patients during discharge, because when we have the value, for me, more than 100 mg% at the baseline during the discharge, so it will be impossible with the current therapy to go lower than 55. So I think that we should go with combination therapy, which should be a topic and subject for discussion. But if we have the benefits, so the earlier is better. So probably we need to discuss that. For me, this approach to check 4-6 weeks before introducing ezetimibe is a little too conservative nowadays, and maybe I would consider earlier, and I will come back to this point. Of course, when you don't have the tolerance of statins, you need to go to ezetimibe. And of course, when we are not able to achieve the good therapy with 2 drugs, you need to go to PCSK9 inhibitors, because this is the only way to achieve targets. So in Poland, we have the approach with the multiple drugs. We are aware of this, statins, ezetimibe, PCSK inhibitors. Even still some centers, they do LDL apheresis, but it's a very small group of patients. Nowadays, it should be overtaken by PCSK9 inhibitors. But what is my thinking interesting for you? We have the group high, moderate, and low risk patients. But more interesting, it is the very high risk group of patients, acute coronary syndrome, established coronary carotid peripheral arterial disease. And we are saying in Polish document that we should go lower than 55 mg%. This was published even before the guidelines threshold. And we have the extremely high risk patients, which are patients with very diffuse coronary artery disease or other territories. And even we are saying in this Polish document that we should be lower than 35, which of course is very difficult to achieve, but we are stimulating interventional cardiologists and peripheral interventionalists to work on the better lipid-lowering profile. Please look that I put here the left main stenting and multi-vessel coronary artery disease stenting, which means that difficult intervention, we should have the very low target with less than 35 mg%. When we go for EAPCI document, which I mentioned, we have this ACS treatment and COVID. And I want to just emphasize that if you look for non-ST acute coronary syndrome, a lot of patients, due to risk of COVID infection, we are saying that in intermediate risk group, they should go for non-invasive testing. Why I'm saying that? Because a lot of patients will go not for stenting, but will go for pharmacotherapy. And I think that especially here, we should be very good with the treatment with pharmacotherapy, including lipid-lowering therapy, because they will be not stented during the pandemic time over last months, or maybe in autumn this year, which I hope will not happen, but who knows. Moreover, we see that all interventions, acute, were reduced by 1/3 in different countries in Europe, based on our survey. But more important, for stable patients, so stable diagnostic and stable angina, chronic coronary syndrome, according to new guidelines, it was just inhibited by 90%. So it will be a lot of people treated just with pharma, no stenting over last month since March, and they need very good treatment. And we see a lot of also patients with delayed presentation, a lot of complications because patients are delayed. They were just sitting home. They are with acute myocardial infarction, heart failure, a lot of problems with mechanical complications. So these patients are really nowadays ill, and they are coming now to hospitals, and this is very important issue. So this is why I'm proposing with our team in Krakow the new way and new approach since May, that we should consider the high-risk patient after ACS. After ACS, I mean during the discharge time. First of all, we introduced in our department for a few years the screening for familial hypercholesterolemia for all patients among acute coronary syndrome. And then nowadays we want to select the group of the high-risk patients after myocardial infarction, and during the discharge to recommend high-dose statin and ezetimibe during the discharge. This is what I said. I think that when you have especially LDL more than 100 mg/cent at baseline, will not reach with high-dose statin the target below 55. So I think that we are losing time not giving this therapy. It's a subject of discussion. I know that it's not fully supported nowadays by guidelines, but it's a kind of new prospective registry wants to prove that is a better approach. As I said, for many years, we have been screening all patients with ACS patients for familial hypercholesterolemia, not to lose those patients. And we know that the few percent of patients among ACS patients, there are patients with familial hypercholesterolemia, our publication from Polish Heart Journal. Moreover, when you see the other publication, this is the European Heart Journal publication, and it was proved that patients with ACS less than 65 years old, with the high LDL, even 8% of those patients were with familial hypercholesterolemia. So to improve the prognosis of patients treated with ACS, I think that we should not forget about also screening for FH in everyday practice. So coming back to our proposal, we are saying let's give a discharge the high-dose statin ezetimibe, control lipid after 1 month. So not just to add statin, but rather to see, not to add ezetimibe, but rather to see that everything is okay with the treatment with high-dose statin and ezetimibe 1 month later for 6 weeks, okay. And additional check after 3, 6, 12 months, because of course some of them will be not tolerating statins. And after 3 months, I agree, we should really focus on reaching the targets. And for some patients, for those patients will be less than 55 mg/cent, if not, consider the PCSK9 inhibitors. Of course, I know that the reimbursement issues are critical. So for some countries will be here 70 or maybe 100, but it depends on the economic status of the country and the system approach. Or when we have the patient with multiple MIs, with the recurrent events, with the peripheral artery disease, many interventions, we should consider maybe less than 40, as we have in guidelines, or even less than 35, as I mentioned in this Polish document. We also think that in our hands, it is important to have support of the remote control, the telemedicine. Telemetry should be helpful, because I think that very simple idea that the patient is able to look at the screen with you over few months, 1 year, that what is the trend of the LDL, glucose, triglyceride, I think it will be very important for patients to understand if they are compliant or not according to our guidelines and expectation by physicians. And I think that it will improve the adherence to therapy and control of targets. So I would like to say that in summary, that patients which we have, I think to improve prognosis for ACS patients for interventional cardiology is certainly not stenting, because this we have almost perfect in our hands in Europe, on also other continents, but we need to improve the pharmacotherapy after the ACS treatment and primary PCI and stenting. And also for patients not having stents to treat optimally during the acute phase and also at the discharge level after discharge. We need screening for familial hypercholesterolemia among patients with ACS. I think especially for young patients, we are trying to do for all admitted patients. It's very easy with the scale. We should have the control of LDL after 3, 6, 12 months, but we should start with the high-dose statin and ezetimibe in the highest risk group of patients immediately during discharge, at discharge time. I think that it was mentioned many times that it should be the great cooperation with general practitioners and using telemedicine tools, because it will improve the adherence of our patients. And we have also some programs and even supported by Ministry of Health for our center. And we are doing quite good with this cooperation with general practitioners. And of course, we should remember that we should take the strong drugs when we need really to achieve the targets. Thank you very much.
Thank you very much, Professor Dudek, for a beautiful presentation. As you can see, Professor Dudek has raised many important and very important issues that I believe will be discussed during the question and answers session, especially when to start with the combination therapy, whether we should really wait 4 weeks in order to consider ezetimibe, whether there is a need, as only it is allowed by the reimbursement, to start with the PCSK9 inhibitors during the hospitalizations. And at the end, it was indeed a beautiful approach of the systematic or system approach, how to manage those very high, extremely high risk patients in the department. And congratulations for this approach. And we all are looking forward to seeing this application, because I believe it will be very useful in everyday clinical practice. Okay, let's have a look how the situation looks like in Slovenia. So because Professor Zlatko Fras is a great practitioner. He's a great experience in the managing of high risk and very high and extremely high risk patients. And I would like to see what is his opinion about this, how to manage optimally patients after acute coronary syndrome. So Zlatko, the floor is yours. Thank you very much.
Do you hear me now? Yeah, I hope so. So I'm very happy that I can participate together with 3 great friends and experts in this very important webinar in my mind, since we are now talking about how to move the optimal treatment of patients with ACS or patients with manifest coronary artery disease better when you move of course the prescription and discussion with the patient, as well as his or her physician, about the importance of lipids. We know from many different studies which followed patients after discharge or after acute event like EuroAspire, and we found that factually after 2 years' time, there are only maybe 30 to 40% of patients factually at targets, and it could be that we can do better by moving this intervention more close and even during hospitalization. But first of all, I'm happy to say hello from Ljubljana, and with this I would like to invite you next year, April. I hope we'll be all vaccinated against COVID to the European Congress on Preventive Cardiology. It will be for the 2nd time in Ljubljana, and you'll have the opportunity also to see our beautiful country if you come. So do plan to come in April to Ljubljana. As I said, I acknowledge very much the initiative of ILEP, and ILEP is slowly becoming an important player in the international scene on lipid-lowering therapies, as well as some other aspects of better preventive cardiology in Europe. And I would like especially to say thank you, Maciej, for all your efforts and, you know, your will to bring us together and to do something well, maybe not so highly recognized at the moment as other international societies, but slowly with the, you know, covering the areas which bigger societies don't. I think ILEP has a great prospect. So what I will shortly touch this evening, so something about targets, so how to decide about targets during hospitalization and before discharge. Of course, we have to discuss on whether we should immediately start combination therapy during hospitalization, as Dariusz pointed already. But here I think we should rely on the outcomes of the cardiovascular outcomes trials still. Then I will show you Slovenian algorithm on, like, I would say, a proposal for better or more optimal post-ACS lipid-lowering treatment, where we acknowledge current evidence-based guidelines, and also we put somehow in this algorithm some of our own experience in this field. Why it is so important? I don't think it's really a need to discuss very much, but we know from live trials that if we decrease LDL cholesterol below 100 milligrams per deciliter, either with statins or even better by combination of statins and PCSK9 inhibitor, in both cases, it's 100 milligrams per deciliter, where we see that the atheroma is not increasing anymore. Factually, we can induce regression of atheroma if we go with the LDL cholesterol to lower levels. So why it is so? Because by having a situation in our body with the LDL cholesterol over 100 milligrams per deciliter, of course, our plaques are more prone to become unstable and rupture more easily. Factually, many times, not only our youngsters, but also GPs and other specialists ask me, which is the truly desired LDL cholesterol? And always I say, factually, I don't know. But what I can assume is the regression from many different big studies, like extensive statin trials, both in primary prevention, where you can see that this regression line of decreasing LDL cholesterol and % of coronary events, you see there is an intersection with 0 at 55 milligrams per deciliter approximately, which means around 1.4 millimoles per liter. While in secondary prevention, of course, in secondary prevention, we have also such a regression line, and can you move the slide? Yes, and here the intersection is somewhere around 30 milligrams per deciliter, which means that we can assume that if we would decrease LDL cholesterol to 30 milligrams per deciliter or below 0.8 millimoles per liter, there will be no recurrent atherosclerotic events. So these are our desires and factually goals, but how to achieve this? Besides, we know that even below LDL cholesterol targets, which are decreasing by new trials, you can see that further LDL cholesterol reduction gives additional cardiovascular benefit. And if we start with somewhere like 4.5 millimoles per liter as a reference, you can see that by decrease the LDL cholesterol to below 1.3 millimoles per liter, we can decrease the risk by 60% only by the LDL cholesterol reduction. And here we should rely on, as I said, extensive large clinical trials. And we are all aware of those old trials with the high initial LDL cholesterol like 4S, then secondary prevention trials, CARE and lipid, HPS high-risk vascular patients, then prove it, treat to new target, improve it with combination with ezetimibe, and finally, the most recent trials with PCSK9 inhibitors on top of maximal statin therapy. And by each of these steps, we decreased LDL cholesterol a bit more, and we decreased also the risk. So here are some quotes regarding this decreasing of targets, and we can say that lowest is best. Just to mention few most important trials from the last 3 to 4 years. As I've said, improve it, demonstrated that combination of simvastatin plus ezetimibe is better than simvastatin monotherapy in decreasing both primary and secondary endpoints. It was quite a long study and extensive one. Then trials with evolocumab and alirocumab both showed that we can further decrease risk for cardiovascular endpoints by further decreasing LDL cholesterol significantly. But now, coming to practice, we should be aware about some facti bruti, and I said conservatively that only about 50% of our patients or even less achieve their goals on current therapies. In EuroAspire showed that it's below 40%. And there are multiple causes for failure to achieve these desired LDL cholesterol levels. There are difficulties with adherence, so patients discontinue frequently the therapy. Then we have a lot of patients where we cannot achieve LDL cholesterol even by the most potent combination therapy. And there are many patients who are unable to tolerate optimal therapy, mainly statins, then limited access to optimal therapy like PCSK9 inhibitors. And we have, of course, gaps in availability or continuity of healthcare, which means here we point on organization. And now, how to solve these problems? What do we really need? Can we better use available drugs? Shall we use combination therapies as it was introduced in the first lecture? Or do we need even new drugs? Here, as I mentioned, I would like to share with you our recent development of the Slovenian Society of Cardiology, the national ACS lipid management algorithm, which follows the European guidelines. We do according to the guidelines testing on lipids, then we prescribe the highest possible dose of statin, either Rosuva or Atorva. And at discharge, factually, we prepare a standardized discharge letter for GPs as well as for patients, and we discuss this with patients. So what are the targets? As mentioned, below 1.4 millimoles per liter and 50% reduction from baseline. So, as I said, we follow the evidence we have from trials. So our first lipid control is after 4 to 6 weeks, and in case we are not on the right path, of course, we add ezetimibe, and then there is another control after 4 to 6 weeks. So altogether in 3 months, we come to the second control where we decide on whether to introduce PCSK9 inhibitors, and this depends on the eligibility of the patient. Why eligibility? Because reimbursement for PCSK9 inhibitors in Slovenia is limited by the national health insurance. We have the reimbursement criteria for both secondary and primary prevention, and here you can see that if LDL is over 2.6 millimoles per liter in patients with manifest coronary artery disease with additional conditions, that increases or enhances individuals' cardiovascular risk, you can, of course, candidate such a patient for therapy with PCSK9 inhibitors. Of course, Professor Dudek already challenged this step, which still we have in our algorithm as to follow the discharge. And of course, if we would join these 2 visits, of course, we can do better and faster. But there are some other issues important, and this is the issue of discontinuation. And first, all patients should be aware what is optimal medical therapy, and they should be aware that in case this optimal medical therapy will not be continued for a long time, they are at significantly increased risk, as showed not only EUROSPIRE 4 and 5 data, but also some other big data, studies with patients after ACS, like these Dutch single center observational studies, where of course, even after adjustment, the hazard ratio is 34% less by using optimal medical therapy at discharge in comparison to those who don't. Then, as I've mentioned, discontinuation is very important. So many patients discontinue statin treatment. So there are data that even less than 50% of patients take statins after 6 months, and we should have this in mind. That's why it's very, very important to follow these patients, and even by using such tools as Professor Dudek mentioned, maybe we can really do better in the near future, because there are, of course, significantly increased risk if we don't do this. And the last point, which is very important, is the continuation of treatment and duration, because we know from studies, not only with statins, also with combinations with ezetimibe and PCSK9 inhibitors, that by duration of treatment, of course, the benefit is increasing. So it's very important that we use these therapies for as long as possible, and as I've mentioned, we should initiate the treatment as early as possible. This should be as aggressive as possible and as comprehensive as possible. So possibly already in the hospital first combination. So we have plenty of guidelines. Currently, we follow in Europe, of course, the last EAPCI guidelines from 2019. I will not go into details. You saw some of the recommendations of the very high class, because the evidences are really of high quality. But there are also American guidelines which are really of high quality as well. There are few issues to be resolved, and we should take this into consideration. We do need more clinical studies, so we are not the most wise at the moment already. We do need more trials or data on safety, especially long-term safety of PCSK9 inhibitors, for example. And of course, we can discuss about the accessibility or affordability of these drugs, especially on price. So to conclude, as clinicians, we should practice evidence-based medicine. We should follow current guidelines, which are backed with robust clinical trials. So here we should discuss those issues mentioned both by Professor Dudek and myself, what to do during hospitalization. We should be aware that there are knowledge gaps significant, which we should overcome. And at the end of the day, we should practice art of medicine. So we should use our own clinical judgment and personal preference in areas in which no reliable or reproducible evidence is available. And finally, many of these areas will be addressed by current and future clinical trials, which were designed specifically to address the areas where knowledge gaps exist. Thank you very much.
Thank you very much, Zlatko, for a beautiful presentation indeed. As you know it very well, it is important because within this presentation, we in fact have many issues to be still solved, and especially in order to be effective in the therapy, in our optimal management of patients after acute coronary syndrome. I would like to kindly ask all the participants, because there are a number of them, as far as I know, it is over 600 even, to ask questions and either to give your comments or your opinion about those issues, about the e-health, e-medicine, how to monitor patients after discharge, what to do during the hospitalization, how to achieve the targets. So we have the first questions, but we will get back to those questions after in the session. But now, if you don't mind, I will follow my presentation. I would like to focus a little bit on how to define extremely high risk based on the available data, and Professor Dudek has already mentioned a little bit approach to this. Why might those patients benefit the most from PCSK9 inhibitors, and why it is additionally important now in the COVID-19 pandemic? So all those questions are important, and I am very sure that we are able to answer those questions. First of all, you know it very well for studies since 4S trial and many other cardiovascular data trials, not only related or linked to lipid-lowering therapies, that if we have more patients at the risk, the potential intervention might be associated with the higher benefit. As you might see in this presentation, we have these were data published and presented for the first time at American Heart Association Congress from the TIMI group. By the TIMI group, and as you can see, there are different risk factors, and then when we add those risk factors, the risk is the highest for at least 6 main cardiovascular risk factors, and then we have the same patients, and when we have the intervention based on the simvastatin and ezetimibe, so based on the IMPROVE-IT trial, if we have this group of patients with at least 3 risk factors, there is a highest benefit with the intervention, with the number needed to treat, as you can see, even 16, 17. So every 17 patients might benefit from those interventions. So the higher risk is, the higher benefit we might in fact expect. When the situation started with the attempts at the definition of the extremely high risk patients for patients with lipid disorders, in fact, it was quite surprising, but all started with the American College of Clinical Endocrinology and American College of Endocrinology, because for the first time in 2017, they suggested that there is a group of patients that might be and should be considered to be at the extremely high risk, and these patients should be with progressive atherosclerotic cardiovascular events, cardiovascular disease, including unstable angina in patients after achieving LDL cholesterol below 70. It should be established clinical cardiovascular disease with other cardiovascular risk factors such as diabetes, chronic kidney disease, and heterozygous FH, and as well as those patients with history of premature atherosclerotic cardiovascular disease. And for the first time in 2017, they suggested that for these patients, LDL cholesterol levels should be even below 55. Professor Dudek has only mentioned about other approach, but first, at the beginning of 2018, there was an approach how to what patients might benefit from PCSK9 inhibitors, and this was approached by the consensus, within the consensus of the European Society of Cardiology and European Atherosclerosis Society. And as you can see, based on this consensus, there was a suggestion that patients with clinical atherosclerotic cardiovascular disease being on maximally tolerated statin therapy with ezetimibe and with the persistent elevated LDL cholesterol level over 140, or those with persistent LDL cholesterol level over 100 and familial hypercholesterolemia, diabetes, severe or extensive atherosclerotic cardiovascular risk, or rapid progression of the atherosclerotic cardiovascular events might benefit the most from PCSK9 inhibitors. So these are patients with extremely high risk that should be treated with PCSK9 inhibitors. This approach, Polish approach, which was very important because, in fact, it reflected all the data. It was in 2018. It was also presented by Professor Dudek, but I would like to a little bit focus on it because, in fact, it was the beginning of the approach when, in the extremely high-risk patients, we might observe not only patients after acute coronary syndrome, but patients with acute coronary syndrome and other previous cardiovascular events. So this is the approach we might have been seen in the current European guidelines, European Society of Cardiology guidelines. Those patients with here we might see the typical interventional cardiologist approach with the stenting of left main coronary artery. But as you can see, we have also patients with, in fact, polyvascular disease, because it is generalized atherosclerosis. It is in fact it is the same that polyvascular disease, and in fact patients with multi-vessel disease. So in fact, as you can see, it was before the guidelines, but it was the same groups of patients that might benefit the most for PCSK9 inhibitors that was repeated in the next approaches. At the beginning of 2019. We published another paper in cardiovascular research when we summarized the data from the available sub-analysis mainly of the Fourier trial, but also of the first sub-analysis of the Odyssey outcomes trial. And we used the approach of Professor Jennifer Robinson that noticed that if we compare not only the benefits from the patients, but if we also take into account the issues associated with the cost effectiveness of the therapy, there is a cutoff point of number needed to treat below 30, for which we know that this therapy, those patients might benefit the most from PCSK9 inhibitors. And on the other hand, this cost benefit is enough in order to consider payment for these drugs by the governments. So if you can see for those patients, there were patients with early, from the epidemiological point of view, acute coronary syndrome, because it was the acute coronary syndrome in last year, and the persistent LDL cholesterol level over 100. There were patients with additional risk factors such as diabetes and baseline level of lipoprotein(a) over 60 based on the data from the sub-analysis of the Odyssey outcomes trial. There were also patients with after acute coronary syndrome and LDL cholesterol level over 70, but also with the inflammation over 3 mg per deciliter, as well as with concomitant peripheral arterial disease, as well as with the previous vascular events and those with the multi-vessel disease, as I have already mentioned. What happened next? As we can see, there was in September 2019, new guidelines of the European Society of Cardiology and European Atherosclerosis Society were published, and we were a little bit surprised because on one hand, we might have predicted that the lower of LDL cholesterol and thresholds will be lower, and in fact it was done within these guidelines, because for very high-risk patients the expected level of LDL cholesterol should be below 55. And obviously it was a kind of attempt to define the group of patients with extremely high risk, but it was surprising for us that only one group was included. There were those patients with atherosclerotic cardiovascular disease who experienced a second vascular event within 2 years. So it was a little bit surprising because, as I have already showed you, we have had enough data in order to consider other patients to these group of patients with extremely high risk that might benefit from PCSK9 inhibitors. What is more, such an approach would have been very, very beneficial for such countries like Poland, like France, like Greece, Bulgaria, and many others, when we do not have enough or very well existed reimbursement plans for PCSK9 inhibitors, because it would have been a very strong document that would help us in the discussion with the government. So we were a little bit surprised with this approach of the European guidelines. Next, on the same Congress in September 2019, we have tried to validate the existing data on the extremely high risk patients definition. within the TERSET registry. TERSET registry, these are patients, consecutive patients at the Silesian Cardiovascular Center. It was based, as you can see, on almost 20,000 patients, and those patients are at a very high and extremely high risk because all those patients are with atherosclerotic cardiovascular disease, and most of those patients are with after acute coronary syndrome with acute coronary syndrome at the admission. And for the whole population, where patients both with the atherosclerotic cardiovascular disease as well as those patients with acute coronary syndrome, we've noticed that not only those risk factors that have been already discussed within the previous approaches, but also left ventricular ejection fraction below 40, so heart failure, prior stroke, diabetic nephropathy, age, atrial fibrillation should be also considered if we would like to define highest risk patients of cardiovascular events, if we would like to define extremely high risk patients. We also tried to do the same in those patients with acute coronary syndrome, after acute coronary syndrome. And again, we've noticed that for those patients with heart failure, which in fact were excluded from most of the clinical randomized control trials with lipid-lowering therapies, as well as patients, elderly patients over 75, which in most of those trials were also excluded, as well as those with the lack of PCF of the culprit vessel, with those with multivessel coronary artery disease, with atrial fibrillation, diabetes, as well as finally in patients with persistent elevated levels of LDL cholesterol should be also considered as those with the extremely high risk. So as you can see, there is still a lot to do. Take into account the analysis, then take into account the cohort studies, maybe randomized control trials, in order to be sure what group of patients should be really defined as these patients with the extremely high risk that might benefit the most from the novel therapies, including PCSK9 inhibitors, maybe inclisiran, maybe other drugs that are going to be expensive. Finally, this is the very new document these are the guidelines of the Polish Society of the Laboratory Diagnostics and Polish Lipid Association, in which we again defined the extremely high-risk patients, which was a kind of reflection of the data we have had so far. So these were patients after acute coronary syndrome with another event. These were patients with acute coronary syndrome with the polyvascular disease, with those with acute coronary syndrome with the multivessel coronary artery disease, as well as those with acute coronary syndrome at FH. It is something that Professor Dudek has already mentioned within his first presentation, but it is very important to remember that those patients with FH and acute coronary syndrome, from our point of view and based on the data we have, should be treated as those with the extremely high risk group, should be in the extremely high risk group and should be treated in order to lower end LDL cholesterol as low as possible. Okay, why it is important? Because we know it very well, and this was beautifully presented by the Professor Zlatko Fras, that if we are low with LDL cholesterol within the intervention, here you have a data based on the evolocumab data, we might not only reduce the volume of the atheroma plaque, but also increase the stability of the atheroma plaque via the calcification of this atheroma plaque. So it is critically important to know, and as you can see, the level is about 60-65, based on the data from Professor Zlatko, it was 57. So it is altogether, if we are around the target, new target, about 55, we should be very, we should know that we probably should not expect any new recurrent cardiovascular events in those patients, and those patients should be treated as safe. Why those patients might benefit the most from PCSK9 inhibitors? Because most of those studies that were used in order to define the extremely high-risk group patients are indeed based on the data from PCSK9 inhibitors. And we know it very well that triple therapy, as you can see, with PCSK9 inhibitors, intensive statin therapy, and ezetimibe helps us in order to be on the target of the therapy, and only with those therapy we might be on the target below 55 and even below 1 millimole per liter. And it was the same within the EVOPAX trial when we used PCSK9 inhibitors during the hospitalization. Finally, it is not only the role of PCSK9 inhibitors and intensive lipid-lowering therapy in order to reduce LDL cholesterol, but we know it very well that not only statins, but also PCSK9 inhibitors might reduce inflammation. And we know it very well that it is not associated with the reduction of the CRP, but in the end, we know that they reduce the infiltration on the macrophage, they reduce the local or regional wall inflammation, that might reduce the TNF-alpha, they might reduce interleukin-6. So altogether, it is another critically important benefit of the PCSK9 inhibitors. Why it is important? Because we know it very well that all those data were based, as I have already said, on the data from the PCSK9 inhibitors. And in the Odyssey outcomes, as you might see, we for the first time notice that in fact persistent levels of LDL cholesterol over 100 might be associated with the further reduction of the cardiovascular outcomes with the intervention. So those patients might expect to have the largest benefit with the intervention, as well as all those with the additional risk factor, as I mentioned, those with the early MI, those with at least 2 vascular events, those with multi-vessel coronary arterial disease, as well as those based on the sub-analysis of the Odyssey outcomes, such as those patients with polyvascular disease, those patients with peripheral arterial disease and venous thromboembolic events. As you can see, beautiful reduction of the risk by almost 30%, as well as those with strokes. What is important in this very important study by Walter Ukema and the group, there was no association between the hemorrhagic stroke and very low levels of LDL cholesterol. That has been an issue that has been discussed in the last several years at least. Why it is important now? Because as you know it very well, in the COVID-19 disease, in the coronavirus infection, we might expect something which is called cytokine storm, which might be associated with the myocardial infection, with the thromboembolic events, and these are the recommendation of the European Society of Cardiology guideline paper. And we also notice in our very recent paper that when we use lipid-lowering therapy with statins and other drugs, we might not only reduce inflammation, we might not only stabilize atheroma plaque, but we might also decrease the risk of the coronavirus infection due to the fact that we reduce the lipid troughs, we reduce the internalization of the coronavirus. So it is so important now to be optimal with lipid-lowering therapy. And what is more, if we have a dyslipidemia in our patients with high levels of triglycerides, it is also important to remember about the omega-3 acids, because we know it very well that those when we use omega-3 acids, these resolvins, lipoxins, and protectings might be associated with the significant reduction of the cytokine storm, and there are at least several new randomized control trials that check and investigate whether there is a causality link between the omega-3 acid treatment and reduction of the risk of the coronavirus infection. Why it is important? Because we know it very well that in all those patients with the underlying cardiovascular disease, these patients are at the very high risk of the mortality, all-cause mortality and cardiovascular mortality, including MI, including stroke, including sudden cardiac death in patients with during the coronavirus disease time. What is more, in the end, I would like to only notice that we should not afraid of lipid-lowering therapy in the time of COVID, because in the very recent guidelines of the European Society of Cardiology, it was only few words about the lipid-lowering therapy, and the only words is associated to the fact that we should be a little bit afraid due to the fact that it might be associated with the myalgia, myositis, or maybe rhabdomyolysis. It is not the true at all, and in our paper, which was published in Pharmacological Research, you might see that if we know what are the interaction between the statins and the drugs that may be used in COVID-19 patients, there is no problem in order to be safe, because for most of those patients we might use rosuvastatin, for most of those patients we might use ezetimibe, and PCSK9 inhibitors are safe, and there is no message on the interaction with antiretroviral, antiviral, tocilizumab, remdesivir, and other drugs used for COVID-19 patients. So please continue your very effective therapy in COVID-19 patients, because those patients might benefit from this therapy and might reduce the risk of the complications of COVID-19. Thank you very much. I would like to kindly apologize for being a little bit late with this presentation, and I don't want to wait any longer, because I would like to see a beautiful presentation by my great friend from Bulgaria, Sofia, from Professor Arman Postadzhiyan. Arman, the floor is yours. Thank you very much. You are with us.
Hello, everybody. It's a great pleasure to be with such distinguished friends, and thank you to Maciej to inviting me on this important webinar organized by International Lipid Expert Panel. Nothing to declare related with this presentation. So in reality, this is a case, a 50 years old male, diabetic. You see the level of glycated hemoglobin, blood pressure, and lipids. Those are on treatment, actually, with metformin, lisinopril, and simvastatin. And he was truly asymptomatic until 2014, when he had a stable angina. You see the angiography, mild stenosis in the proximal part of the LAD, and a significant one on the middle part of the right coronary artery, which was successfully stented with a drug-eluting stent with a very good angiographic result. So the patient was discharged according to the guidelines on 40 milligram rosuvastatin. After 1 year, you see very good results related with the target of the LDL cholesterol. And because this is a true history in reality, so that's happened in clinical practice, this therapy was de-escalated. After that, we have a de-escalation to 10 milligram rosuvastatin, to 5 milligram rosuvastatin. You see the corresponding level of the LDL cholesterol. Here we have a consultation with endocrinologist and another change of the therapy on combination lipid-lowering therapy with simvastatin 10 milligrams and fibrate. Just because the triglyceride levels are 3.3, and you see the dynamics until the 2018. Unfortunately, the patient came into the acute settings with acute myocardial infarction without ST segment elevation. Nothing happened on the right, on good condition, but you see a clear progression on this lesion onto the left arterial descending artery. Another stent was placed. Another drug-eluting stent was placed, and after proximal optimization, we have a good angiographic result. Can you help me a little bit, because it doesn't react according to... Okay, this is the lesion. The next one, please. Okay, so this is the result after proximal optimization of the lesion. So this guy in our days is quite famous, unfortunately, with the history of shipping, which is a little bit ridiculous, but in generally, he's a brilliant mind. He had a lot of good things in his life that he was still and give to the society. And so this is one of the ideas, is that the humanity's greatest advances are not in these discoveries, but how those discoveries are applied. And of course, LDL is causal for atherosclerotic cardiovascular disease. So this is the idea that we all appreciate. So the question is how we apply those knowledge. And in reality, we must not remain idle when we know that most patients are not provided the opportunity to benefit from our major therapeutic advances. this is quite important, and the patient-doctor relationship are of crucial importance. And here, at least, we have three things to think about. This is to be aware, to learn, to trust of the data that we have, and to have some good action plan in order to be more precise in our everyday clinical practice. So last year was the first that my country participated in main measurement month, a global campaign of International Society of Hypertension. The majority of the patients are aware about the problem of the hypertension. We found relatively low new patients, but see what's happened about the control of the blood pressure for those having antihypertensive medication. Part of the problem was a relatively high number on patients with monotherapy and relatively low number of patients on fixed dose combination. And now we are aware about this, and so it means that the guidelines, for instance, of arterial hypertension who are from 2018 are not applied accordingly. Or another example, this is the registry of FH on Bulgarian Society of Cardiologists. And you see here the mean level of the LDL cholesterol in different centers. This is level of the LDL on treatment with statin. And if somebody doesn't believe of the relation of the LDL cholesterol with cardiovascular event, please see that a significantly high number of patients already suffer of myocardial infarction or stroke or have different combination of atherosclerotic cardiovascular disease. So one of the mistakes that we do is to compare different type of option. If in everyday clinical practice we use syntax trial as a good way to see what is the best option in the complex patient with coronary atherosclerosis, why not to believe of the evidence that we have from this same trial on the optimal medical therapy? And this is a reminder that we have a clear reduction of the death rate with any type of cardioprotective therapy. This is true from antiplatelet, but also from statin, race blockade, beta blockers, etc. And this is quite important to be aware with those data. Another thing is the trust. Another important aspect, see that the death and the major vascular events can be avoided, and of course this is something as a principle in the preventive cardiology, that the patient with the highest global risk benefit the most of these interventions. And as Zlatko already mentioned, of course we have good capacity to increase the results that we already obtained by increasing the duration of the therapy. And all these data are into the guidelines, and if you see inside, we see a lot of class 1A recommendation or class 1 recommendation at least. So in real practice, if we don't apply class 1 recommendation, it means that it doesn't work properly according to our knowledge in our day. Finally, it's of course very difficult to talk for the action, but see a relatively see the data from the PROVIT trial in the field of the patient with acute coronary syndrome, but the proportion of the patient on high-intensity statin therapy that achieve the past, of course, recommendation on LDL therapy. So a significant proportion of the patient achieves these, of course, if we treat them with the high-intensity statin therapy. And because we talk a lot about the tolerability, please see that the side effects is absolutely zero, and the only side effect, if we can talk for this, is the reduction of the myocardial infarction and the death in this trial. So we must believe on this, and we must take action to change our real practice and not using very high-intensity statin therapy. Another part of the problem is the communication with another kind of specialist. They may be not obligatory LDL-centric. They may focus on triglycerides as a part of the therapy. But once again, the same statin, different dosage. And if we increase the number of the metabolic syndrome parameters, we have a different reduction of the event, especially into the patient with diabetes, into the TNT clinical trial. Another brilliant explanation is the introduction of imaging technique into the new guideline on dyslipidemia as a part of increasing our knowledge first, and maybe also as a possibility to involve the patient into the follow-up process. So this is important because, as already was mentioned, please see that the absolute reduction of the risk into the patient with multivessel disease is significantly higher than into the patient not having multivessel disease. We must appreciate this and to communicate with the patient. And if we have already the information of the coronary anatomy, this is a good way to found the patient in which we can intensify the lipid-lowering therapy and strategy. Finally, this is an example in the field of hypertension, but I think it can be applied also in the field of lipidology to have the time at target. This is a very huge database in Great Britain, and if you see those patients who had controlled blood pressure for all the year, had a 47% reduction of all-cause death and a 74% reduction of the major adverse cardiovascular event. And if we compare these data with maybe one of the best trial in the field of hypertension, which is the SPRINT data, you see that it's at least double the beneficial effect of our strategy. And if we compare here what is the difference between the first and the last lipid-lowering effect of our treatment, here it's relatively low. The delta of the LDL is only 0.2, but with the best results that we have, and the last one, we have a huge distance, which is absolutely related with the variability of the LDL during the treatment. And this variability is also related with the cardiovascular event. If we have such kind of treatment, of course, we have worse prognosis on the patient. Finally, maybe there is something good related with the COVID infection, and this is that the technology is going better and better. So we can apply this like some internet tool or something, like we may increase our knowledge, which are those patients who are an extremely high risk in reality, in order to identify the therapy, and after that to communicate with them. And I think that with all these internet-based education and tools, we will have a great success in the future in this field. So, should we densify the patient therapies, not only related with lipid lowering, but also anti-hypertensive and also anti-diabetogenic? I think the true answer is absolutely yes, but the basis to answer this question is that we must not remain idle. So this is fundamental in order to change our thinking. Thank you for your attention.
Thank you very much, Arman, for a beautiful presentation. So we have now time for discussion and now time to answer the questions. And I would like again kindly ask all the participants in order to ask questions. We have first 5-6 questions, and I have just received also to my cell phone, which is, as you can see, we are very innovative, the next few questions from my colleagues from all over the world. So let's start with the first one. I believe it is quite interesting, because if we have a patient, if our patient has LDL cholesterol more than 190 and triglycerides not high, and there is no secondary disease such as hyperthyroidism, could we say she definitely has FH? What is your differential diagnosis for him except FH? So I believe, if you allow me, Obviously, it is not only it does not meet all the issues associated with the diagnosis of FH, even phenotypic FH, because 190. We need to know whether this patient is on the treatment, because if this patient is on the treatment, optimal treatment, for example, with intensive statin therapy and ezetimibe, we should calculate LDL cholesterol based on the algorithm, even, and it might be even more than 325, and the score is 8, but it is not still a definitive diagnosis of FH. And when we look at the other risk factors concerning the history, we might confirm or not. In what other situations such high level of LDL cholesterol might be expected? It might be also familial combined hyperlipidemia. It might be also some metabolic disorders such as obesity and atherogenic dyslipidemia. It might be after drugs. Remember, I've just had a person on antiviral therapy, and the level of LDL, because this person was on the antiviral therapy over 3 weeks, and LDL cholesterol increased from 130 to 195 being on this antiviral therapy. So also please remember about the drugs. But this is my experience. Zlatko, Arman, Darek, what do you think? Obviously, the answer is that we cannot definitively diagnose FH based on this data, but what are the other reasons of such high level of LDL cholesterol based on your practice? Zlatko, maybe.
You know, in so many cases, it came out that factually it is familial hypercholesterolemia if we would do genetic testing in all these patients. But in so many patients, we can come to the diagnosis by, using the questionnaires. We do have very good experience with Dutch Lipid Clinics questionnaire. But in those rare cases where we don't have this data, and in case a particular person is still at so high LDL, of course, we treat him as he would be FH. Mm-hmm. Even if we don't have either definite, very, very probable or diagnosis in this.
I believe it is very important because based on the very recent guidelines, we should all remember that patient with only risk factor, which is LDL cholesterol over 190, should be treated as this with at least high risk, with high cardiovascular risk. So the suitable treatment with intensive lipid-lowering therapy should be given. Arman, an experience of yours?
Maybe quite important thing will be what kind of additional risk factor are present, because this is another type of change of the new guidelines. That so the first is the thinking. It is possible that the patient already had FH, but even though we have the possibility to see what are the other risk factor. And even if in different countries there is no possibility to start a therapy with the PCSK9, if the other therapies, if the other risk factors are present, we may change something related with his blood pressure, obesity, or another risk factor which are present.
Okay, Darek, any comment? Do you have many patients?
So I'm looking, mainly as an interventionalist, so like Bill Gates, to achieve the target. So I would go just with the LDL as low as it is possible. And if you want to be very careful with the diagnosis, you can do genetic tests. So when we have doubts, so still we can have this opportunity. But the most important, even if you have the full diagnosis, if you have the complete diagnosis or not, you need to lower LDL, especially if a patient is after cardiac or peripheral events.
But we all agree that we do not wait for the final diagnosis. We start treatment immediately in order to lower LDL cholesterol. Okay. Exactly. We have another very important question from my cell phone. So as I said, I feel a little bit innovative person just now. And probably it is something that I like the most, so my colleagues know what to ask us. What do you think about the combination therapy, intensive statins and ezetimibe, and or PCSK9 inhibitors during hospitalization in patients with acute coronary syndrome. So it is something that Darek has mentioned during his first presentation, not to wait for 6 weeks. So I would like to start with Darek. What is your approach, and whether you will try to convince your colleagues from the European Association of Percutaneous Coronary Intervention in order to put it to the recommendation to start immediately with the intensive therapy with a combination, maybe double or triple therapy?
The question is perfect. I think, of course, that we need more evidence, but to be honest, for the clinical perspective, I didn't want to say today that I am thinking during the first day to start administration of both drugs, because I was scared that you would be not looking that I'm too aggressive in terms of the therapy. But for me, it would be better to start earlier, because nowadays you will have patients 2, 3, 4 days for the hospitalization. So even it would be better, let's say, second day, and to look for patients at 2 days that everything is okay with the all combination of drugs, including statin, high dose, and ezetimibe. The only comment is that, of course, we have the different patients. Please remember, there are some, patients that are very good, but some patients are with heart failure, some are intubated. So, of course, all those difficult patients maybe is not the best target. But for patients, let's say, with the regular so-called MI, STEMI or NSTEMI, and just stented and going, so I would be happy to start even earlier to see 24, 48 hours in hospital that everything is well set.
Okay, Zlatko, Arman, any comments on it?
Yes, if I can comment, as it was mentioned, indeed, we lack evidence on such an approach, since we don't have evidence to use ezetimibe in during 48 to 72 hours after the event. Of course, if we assume that also ezetimibe has some immediate effects on the inflammatory part of the whole situation in the ACS, of course, it's reasonable to think about. But that's why I pointed that also the ESC guidelines have actually put like this period of 4 to 6 weeks to see what is the level achieved by the highest dose of statin, as well as whether statin is tolerated in this highest dose. But from the practical point of view and from the point of view of adherence, I pointed to the fact that it's very, very important to use the patient when he or she is hot, so to say. So this is during the hospitalization. And in such a situation, of course, it would be desirable to try to start with combination. For example, we discussed several days ago on this combination pills. This is from the point of view of a practicing physician, and as I said, we are ethically obliged to do the best for our patients. While on the other hand, there are some regulatory issues which are based on evidence and the reimbursement issues. And in our case, because people are not willing to pay from out of the pocket for their drugs, because most of their drugs are reimbursed by the National Health Insurance, and ezetimibe is to be co-paid at the moment. So it is only paid for those who are intolerant to statins or familiar hypercholesterolemia over 3.6. So it's very, very difficult. But personally, I would agree with such an approach. Look, I don't see any reason why not to, because IMPROVE-IT was so nicely done, and we have these proofs now. So.
But you agree with me that on the other hand, the IMPROVE-IT was a trial when we saw only 6.4 reduction of the cardiovascular outcomes in 7 years follow-up observation. But on the other hand, I have a tricky question, maybe started to Arman to answer it, because do we really expect that we will have new designed randomized control trials in order to check whether combination therapy given during the hospitalization with intensive statin therapy and ezetimibe, or maybe triple therapy with PCSK9 inhibitors. We have data from EVOPAX and as well as from similar trial with alirocumab, will reduce cardiovascular outcomes, knowing that the lower is better for longer, the earlier, the lower is better, and so on. So it is my personal opinion that I do not need such a trial in order to be sure that it will be a benefit for the patients. But Arman, and I would like to ask you for your opinion about this.
I also think that we have enough data in order to have this. There are maybe two aspects also. First is, do we have a patient who already take a statin and he came in the hospital with an ACS based on the statin therapy? So in this case, from a practical point of view, so my decision to give him ezetimibe as early as possible or during the hospital stay will be here. And the second aspect, I truly like very much this TIMI approach with the how to find truly high risk patient. This is most clinical, and frankly talking, we see this absolutely the same even into the field of antiplatelet agents. So once again, the same clinical parameters define which patient will benefit more from prolonged type of therapy. So they are absolutely based on the clinical issues, and they must be applied. And at least in my practice, if I have TIMI 2 risk score more than 3, in reality, I start with ezetimibe.
Okay, thank you. Okay, let's move to the another questions because we have a lot of them. Please still, if you have any questions or comment, please send us to us because it is your time in order to receive all the answers for your everyday clinical practice. Okay, the second question: patients on high to moderate intensity statin therapy with COVID and high liver enzymes secondary to COVID, would you stop statin and use alternative therapy? What is your opinion about this? Because I have very clear opinion about this, but I would like to first to hear your approach and what to do. Especially we know that COVID might be associated with many inflammatory organ diseases, and it might cause many complications due to the cytokine storm. So what would be your recommendation for this patient, for these patients, for these physicians that they take care of this patient?
So, look, first of all, it depends on to which level liver enzymes are elevated. If they are extremely elevated, more than 3 times upper limit, of course, I would think about the dose. Because it was said either it is high dose or moderate dose. So in case it is high, we reduce this. But otherwise, I would not recommend to stop the statin treatment because you've already gave an answer. So I'm also on this side, so not to stop.
You know, this question is quite tricky because from one side, you know it very well that if it would be a patient without COVID, we might expect after statin therapy an elevation of especially aminotransferase alanine. But we know it very well on the other hand that it is one of the most critical reason of the statin discontinuation, what is the largest mistake, because it is usually temporary elevation. And based on our many data and based on our strict collaboration with hepatologists, we know it very well that statins are recommended for all patients with chronic liver diseases. But this is another completely different situation because it is cytokine storm. We have a virus. We have a completely different reason of the liver disease, which might be acute. And in this concrete situation, I would probably, it is my personal opinion, but it is only based on the expert opinion without any data behind, to lower the dose of statins and to monitor the situation, the aminotransferase, as well as as far as lower, obviously, and that ezetimibe, because ezetimibe is not associated with the liver adverse events at all. So that is why it would be my approach, but it is obviously a completely new niche, new area that needs to be covered with the data, and probably we are not able to finally answer these questions. Arman, Darek, any comments from your side?
Maybe the same in reality is my thinking. If the patient is already taking high intensity statin, maybe I will go back a little bit to introduce moderate dose, but of course it's related how many times the aminotransferase are elevated. So the commentary of Zlatko is absolutely right.
Okay,
I think
Darek?
that basically we should treat the patients as we are treating. I know that the cautions that you mentioned are important, but I remind you that during the pandemic there were a lot of fake news. There were recommendations to stop many drugs, which is not true, and there were recommendations to use drugs to treat COVID, which were harmful and not helpful at all.
I believe it is very important comment, because I was completely against the recommendation of the European Society of Cardiology. But when, as I've mentioned during my presentation, it was 55 pages of the information about the different management of the different cardiological complications after COVID. And when I would like to find the information about the lipid-lowering therapy, it was few statements, and only one was mainly associated to the fact that during the coronavirus, we might expect that it might be a rhabdomyolysis, and we should consider discontinuation of statin therapy. So no information that statins might reduce inflammation, no information that statin might reduce the replication of the coronavirus, taking into account the data from the previous coronaviruses, and no information that statins might simply reduce the risk of cardiovascular events. So I believe it is very important to be very careful when we decide finally to stop the therapy, because it might be harmful for our patients. Okay, let's move further with the third questions. I believe it is a beautiful question for Zlatko, taking into account the very recent paper. It will be soon published on the aspirin. So, role of aspirin in COVID patients with dyslipidemia in the moderate to low risk categories. So, what is your opinion about this, Zlatko? Taking into account, probably taking into account that during the COVID, in COVID patients, we might expect the higher risk of the thromboembolic complications, right?
Yeah, that's one aspect. Despite it's a bit different mechanism of activation of coagulation, but I think the question is tricky from 2 points. It's the one is whether to introduce this as a prophylactic measure to reduce the cardiovascular complication, and the another is to use the aspirin as anti-inflammatory and COX-2 inhibition. So my position would be, and it's also related to the effectiveness of aspirin in different I would say situations. We don't take into account saying that one size fits for all, like 100 milligrams for every patient. I would recommend in this case moderate to high doses of aspirin, which would probably play both roles, so antiplatelet as well as anti-inflammatory. And of course, you know, I assume that in the future we will have to pay more attention to the body weight dosing of body weight related dosing of aspirin in clinical practice.
Yeah, I believe it is very important, right? Darek, Arman, any comments on it? Okay.
This is especially true for the patient with diabetes, I think. And once again, of course, this 325 milligram, which is used in US, it's not without clinical proof. So I agree with the comment on Zlatko.
Okay. We have another beautiful question from Beata from Poland, I guess. If we might see this question, because it is quite long, may consider immediate combination therapy in patients with myocardial infarction with baseline LDL cholesterol above 4. So I believe it is over 160, and based on the Tercet registry, for example, we know that even 10% of our ACS patients might have in LDL cholesterol over 160, assuming that combination therapy might lower LDL cholesterol by about 65%, which means that there is a real chance in order to achieve LDL cholesterol level below 55. So the question is quite good, because if we know from the very beginning that we will not be effective with the statin therapy only, because statin might reduce LDL cholesterol level by 50%, so maybe we should have the final decision what kind of therapy we use during the hospitalization, maybe based on the baseline level of LDL cholesterol. And in this situation, if we have the LDL cholesterol very high, we should consider a combination therapy at the very beginning, immediately, in order to be on the target. Because even if we have a 100% response rate for statins, it is not a chance in order to be on the target with LDL cholesterol over 160. It is based on our experience, animal trials, animal data, and so on. But it is the question for you, obviously. Arman.
So as I said during my presentation, yeah, because I said during my presentation that I was considering even that LDL more than 100 is sufficient for me to consider the double therapy treatment. Why? Because with the current knowledge, it's almost impossible when you have 120, 30 to achieve with the high dose statin LDL below 55. So that's why I fully agree. We need to find the appropriate threshold, but basically when we know that it would be impossible, so why to wait?
Okay. Arman?
So I absolutely agree that the level of the LDL are quite important, but for a clinical point of view, there are a lot of another important modifier. And the patient doesn't have only LDL cholesterol. So if for instance, this is a multivessel disease patient, if he had multiple risk factors, of course, this will be a clear yes decision.
But on the other hand, if you have, Arman, a patient after acute coronary syndrome at the admission in the hospital with the acute coronary syndrome, and you know that this patient was not treated at all previously with statins and ezetimibe, with any other lipid-lowering drug, and the level of LDL cholesterol is very high, for example, 100 at 70. Do you think it is enough in order to start with the intensive statin therapy and ezetimibe? Because then you might expect that the level will be below 55 after 4 to 6 weeks, when we have a full response for the therapy, or you should prefer step-by-step approach with the intensive statin therapy, and after 4 to 6 weeks to consider adding ezetimibe.
Once again, practically, if a part of the level of starting LDL cholesterol without treatment, this patient had more than 3 criteria on TIMI risk score, I will start a combination therapy.
Okay. From my point of view, taking into account, for example, Odyssey outcomes trial, when we have patients over 100 only with acute coronary syndrome, early acute coronary syndrome, it was completely enough in order to know that these patients will benefit the most from the PCSK9 inhibitors. That is why it is my personal opinion, because we might argue due to the lack of the evidence, in fact, in the end. But I believe we are at the moment that we need to find the solutions in order to start the combination therapy during the hospitalization, because I believe if we would like to be on the target, we need to find a good recommendation for physicians, because they are completely lost how to have their patients on the target after the treatment. Zlatko, any comment on this?
Yeah, of course. Look, I can agree with you. So, at certain points, we have to rely on our clinical judgment, experience, expertise, and assumptions. And this is also, you know, if we just take the case of adding ezetimibe to rosuvastatin or atorvastatin, actually we don't have any large clinical trial to prove this, but improve it with simvastatin factually is enough that we can assume that this works with all statins and even better with rosuva and atorva. So that's why I've mentioned that certain and probably the greater part of this action is due to LDL lowering by itself. So that's why I fully agree with you, and if we project this, even by having 100, for example, as Arman said, without having statin. So now, if you add the full, so maximal dose of potent statin plus ezetimibe, you can come to the level where in Odyssey outcomes or Fourier we came with PCSK9 inhibitors, and nobody can say that we cannot expect the same level of effect, at least, even from some aspect, maybe more. So that's why, Maciej, I agree with you.
Okay. Okay, we have another question, quite tricky one. Have you seen during the pandemic so far that patients who were on statin or PCSK9 inhibitors therapy were protective against COVID or had better outcome and recovery? I can say that there was a trial in Lancet published by the Harvard group that noticed that statin therapy was associated with the almost 30% reduction of the cardiovascular death and all-cause death, but it was retracted in the end due to the fact that the authors were not able to get the patient's data, right? So I know very well, because I have been working with the UK Biobank and my colleagues from US mainly from New York, that we have been working on the data on lipid-lowering therapy, mainly with statins and ezetimibe, but there are also some patients with PCSK9, but it is going to be published soon. But you might also find the data from Oxford, which is in preprint still, that showed that in patients with statin therapy, there is a significant reduction of inflammation, oxidative stress in patients with COVID-19, but it is still without any influence and effects of cardiovascular events. So it is still a kind of hypothesis, very, from my point of view, very realistic to take into account the properties of statins and lipid-lowering therapy. But obviously, if I would like to answer clearly for this question, we need to wait for the data in order to be sure that statin therapy and lipid-lowering therapy might be really beneficial, taking into account the reduction of the all-cause mortality mainly, right, for in these patients. Okay. Any comment? My apologies, because I'm a very talkative person and you need to apologize me.
I can just say that I don't have enough personal experience. Just what I can say is that those patients, very rare, which were on statin, and I had information on their positive infection, that the treatment was continued with no complications.
Okay, we have many good comments on our webinar. For example, with my great colleague from California, Professor Nathan Wong. Zlatko, you know Nathan very well, so it is great to see you all on the ILEP program, and excellent talks by all the leaders. Hopefully, bempedoic acid in combo with ezetimibe. As you know it very well, the data has just been published and just been presented at the American College of Cardiology meeting. Is now available in US, will be a major player for statin intolerance and people needing additional LDL lowering beyond statins. And it is obviously true. We have been waiting, for example, in Poland also, and I know it very well that we have been, in fact, waiting in order to be approved in Poland and in Europe to be available, because we have enough data based on the fast-free and pool analysis of fast-free trials in order to have this drug available. You know, and find the good information is that it might reduce LDL cholesterol level by about 25%. In combo with ezetimibe over 40%, so it is equal to high to moderate intensity statin therapy. But additionally, it might reduce CRP by about 30 to 35%. So it is another very important drug that might be considered in patients with the high level of inflammation, which is an independent risk factor of cardiovascular disease. Okay, we have another comment, I believe very important. If you might show the final comment by my great colleague from Saudi Arabia, Professor Fahad Al-Nauri. Patients admitted with acute MI or ICS, their lipids profile does not really reflect the severity of hyperlipidemia. It is true. I would like to ask Darek for the opinion. It is usually less than the real numbers. Therefore, I would start aggressive lipid-lowering therapy in form of the dual treatment. Can you show this comment? Because I believe it is very important, because it is the true in the acute phase of the acute coronary syndrome. Indeed, the levels of LDL cholesterol might be completely different than in real life. So, Darek, what is your experience on this?
I fully agree with the comment, and we spend a lot of years saying that the measurements of lipids are not appropriate during the acute phase. But if we don't measure, we have no data, and we don't know how to recognize patients, how to treat. So I think it's better to start therapy, especially when we see in those acute settings the high levels, so it means that it will be only higher. So I agree that we should be very sensitive, even in acute phase, to check and to treat. Okay,
Zlatko, Arman?
Yeah, what I can say is that we have clinical path that the blood sample is taken and we have the lipid levels. But as Dariusz said, even if we would not have this, we should treat with the highest possible statin treatment from the very beginning, since by this we can significantly reduce the first recurrent events, as we all know from Miracle study, and that's why this is in one of the imperatives.
Arman, any final comment?
And also in relation with possible or probable FH, it's important to have the starting data on ACS in the hospitalization.
Okay. So these are all the questions and comments, because we have also a great comments and gratefulness for the webinar from Sławomir, from Peter Penson, from Liverpool. Peter, great welcome for you, and Nasrin and many others. So thank you very much. We are very glad that the webinar was hopefully very useful for you. So taking this opportunity, I would like to kindly thank you all the participants, first of all, because it is for you, not for us. First of all my great experts and great friends and colleagues, Professor Zlatko Fras, Professor Dariusz Dudek, Professor Arman Postadzhiyan, because I believe that we have tried our best in order to explain all the tricky parts, tricky elements associated with the lipid-lowering management in patients with acute coronary syndrome. So hopefully we are able to do it successfully. And finally, I would like to kindly thanks to our partners, Amgen and Sanofi, because without them, we weren't able to prepare and organize this webinar. So taking this opportunity, I would like also to inform you that all the previous webinars, if you were not able to see it, are on the ILEP EU webpage. The full recordings are available, so you might see the information about the lipid-lowering management with high-risk patients, the first webinar, the second, and about the adherence, compliance, the second webinar on FH, and this one will be also available tomorrow. So please feel invited in order to see in your free time. And thank you very much. I would like to wish you the beautiful evening in Ljubljana, Krakow, and Sofia, and also in Łódź. So best wishes from Łódź. And I would like to kindly invite you for the fourth last webinar, which will be on Friday at 7 p.m. Thank you very much, and good night.
Thank you.
Thank you, pleasure. Thank you. Bye.